Thank you for staying for this talk. You know, the idea of this talk developed in a board meeting, which means sitting in the corner of cups and saucers, you know, the coffee shop downstairs. And I boldly thought, well, why don't we just come up with some sort of acronym that would suggest that we actually know what we're doing clinically. And at the time I thought calling it GRACE, or Genomic Research Advancing Clinical Excellence, just seemed to have a buzz to it. Little did I know that I had opted and agreed to take on probably the biggest challenge in the post-human genomic world, because everybody's asking how we should actually move from bioinformatics to clinical medicine. Now, Marita and her co-workers have done a magnificent job in giving us ways to diagnose certain treatable conditions, facilitate lowering of cumulative risk, and formulating intervention programs. And that's really given us a bit of a handle in this new world. But I realized as a clinician that I would have to change my perspective, because it's a lot different when I'm in my practice than what it's like when I'm working in a lab. And before I give that perspective to you, maybe I should just explain a little bit about my background. Now, I know I'm an immigrant, which means I qualified at Tuckey's. 10 years later, after 1991, 10 years later, I had the opportunity to redo my degree in America, doing all the United States medical licensing exams, and the greatest value was actually relearning biochemistry and some of the basic fundamentals of medicine that had changed so much. I did a one-year fellowship, clinical and research at Duke University. I've practiced both in America and here. So I've played around with rats, chemicals, and humans ad nauseum. But I've also faced the triumphs and tragedies, the mistakes and breakthroughs of clinical medicine. So I understand that world. I've dabbled in diving, aviation, hyperbaric medicine, wound care, even vestibular and balance rehabilitation. At Duke University, I actually did a course looking at faith and spirituality as a way to really ground and assist people in helping them make sense of their lives. And it really is a very much pro-physiological thing if done correctly. But a couple of years ago at Unitas, I think it may have been the first gene care, one of the very first gene care workshops, and subsequently here, I attended Marita's initial efforts and ongoing efforts to make sense of this landscape. And that got me tweaked. And then at some stage, Susanne roped me in because she needed a pet doctor to help with the MS patients. And of course, that got me into the system, and there were these weird numbers that previously I had no real recollection for that I now needed to understand. Marita was close on her heels and started involving me. And then I started becoming involved in different ways within this world. And the fascinating thing was that I realized that there is a tremendous difference between the genetic researcher, the genetic counselor, the specialist, and particularly the oncologist, versus the general practitioner. Because I actually had the privilege of working to some extent in each of these four roles. And I realized that even though the material was fundamentally the same, my approach was entirely different. And I had to think about, how am I going to start this process? Because you see, I was spoiled from the start, because Susanne and Marita would give me the report, say there's a patient coming in a while and you'll need to talk to them. So I just had to brush up, read the report, see what the primary health concern was, confirm that the actual information the patient had provided when they entered the report was the actual information that was clinically true, and then explain the report using examples and illustrations, dispel alarm, make it relevant, motivate them, change any prescriptions with consensus with their GP or specialist, and perhaps refer. But these people were pre-screened. They were sent to me with all the information. All I really had to do was to explain what was in front of me. And that was so different from the role that I have played in my practice. Because in the genomics referral, I was really, in a sense, a genetic counselor, working with a fairly well-understood agenda and interpreting results I had in hand. The researcher has limited contact, But again, the subjects are typically informed, know why they're there, and the information is then something that you need to transmit and, of course, study. And the oncologist or the specialist understands, or the patients do, when they get to them, that they're coming for specialist assessment. So them introducing a genetic test isn't sort of out of left field. It's understood that it's probably part of unraveling their disease. And in oncology, which is leading personalized medicine, I think, to a large extent, there's tremendous literature supporting what sort of testing we can do and how it impacts on the clinical management. But the wild card was on that side of the line. When I was working in my general practice, where did I even begin? How did I open the conversation? How would I get someone even interested in undergoing the testing, other than imposing it, suggesting it as something I'd like to do, which, as the counselors here will know, is not the best way to start the conversation. They need to understand where they're coming from and going to, and how the test fits into that solution. And that's really what I tried to do with this talk. Now, I apologize in advance that it's going to be practical, and it's going to be something that a clinician hopefully can use to some extent. It's not definitive, it's a conversation piece. So, hold on to your seatbelts. We've come a long way with the unraveling of genetics, and it's changed and it continues to change. Medicine has changed also. Previously, we had clinical examination and individualized sort of empirical approaches to patients, whereas now most of our common interventions are based on probabilities, risk management, screening, and that is an entirely different approach, and that's led by evidence-based medicine and managed care. It's a different flavor and it's a different world. So many of the assessments we do are really prescribed by risk and probability rather than examination and critical thinking. And that has shifted things a bit, because there are now all these standards of care that we need to include in the way we practice medicine. Patients have also changed. They have access to information, and I know that we serve a tremendous population of even destitute and impoverished people. But they have access to cell phone technology and information that is often mind-boggling. And we should not ignore the power that that access and that technology offers in the world we are about to enter. And then, of course, we also have some of the other side of the spectrum. Highly informed, technically preoccupied, somewhat hypochondriacal and information-seeking individuals who then come to you asking answers to questions for which they actually have had access to better information, even though they may not necessarily have been able to interpret it properly. But it's a completely different world, and as a clinician, we're intimidated because we don't quite know what to do with this. We don't quite know how to engage. And that's what I'm trying to unpack. Genomics is there to stay. The technology that is going to make genome-wide assessments and associations and all the other things that we've spoken about earlier today is imminent. The information's coming, and we will have to face the technology that can help us interpret this and process that and reduce it into ways that we can take it to the bedside. But for now, it's a little bit like having a laser pointer on an IMAX screen. It's very bright where it shines, but it's not illuminating the entire canvas. And what we need to do is to make the best use of what we have. And I think that is where this audience and the people here are trailblazers, because we are moving beyond the former world of classic genetics into new genetics, where literally, day to day, we are getting better resolution on clinically useful genetics, packaged in ways that are easy to order and, thanks to pathology-supported genetic testing, a lot easier to interpret. Now, let me turn to the clinical side. Where do I stand when a patient comes to see me? Well, what I realized was the first thing I had to really clarify for myself is what my role was. And these aren't watertight compartments. We shift. And if you're not a general practitioner and you're sitting here as a dietitian or genetic counselor, please listen with an attentive ear, because I know that some of these things will be relevant to you also. And perhaps in understanding something of our world, we will notice that we have more similarities than differences. But what I've realized is that there are really three styles in which I would engage with a patient. Either as a coach, interpreting information that they would apply, surveying their health, which may include monitoring medication or looking for the manifestations of disease under a screening program, and then occasionally to intervene, either through prescription or through procedures. I realize that in a coaching role, this is usually something directed by the patient and frequently unfunded. So that narrows down the type of people that usually would interface with us. On the other hand, on the intervention side, the genetic testing is increasingly being supported and included in the funded services by medical aids. So the anvil at the moment is this environment of pharmacogenomics and maybe other additional risk factor management aspects that we now need to carve out. As people, as patients, increasingly bombarded by media every day, confront the reality of the social philosophies and the social factors behind many of the modern illnesses, they are faced with a major confrontation, because there is virtually an impossible number of things you can do. You can walk down Pick and Pay's aisles and you can exhaust your entire month's grocery list supplementing or doing other purchases to improve your health. And then there's, of course, all kinds of instructions to run and to this and to that. You literally could spend your entire day just maintaining your health. And many people eventually reach a stage where they have a couple of pet things they do. They tend to stick to them, sometimes almost with a religious zeal, and they settle on these in a way that may or may not be in their best interest. Now, Francis Collins, in his landmark book, I must say, called The Language of Life, does a wonderful job of giving us the history, evolution, and the scope of personalized medicine. If you haven't read the book, it's a worthwhile read. It's available as an audiobook as well if you need to listen while commuting. But one of the key concepts that he brings forth that this form of genomic medicine introduces is its capacity to be a transforming agency. In other words, it provides us with a means to assist people in establishing their risk, absolute or relative to the remainder of the population at risk. The burden of disease, how bad will it be if you get this disease? And finally, what interventions may offer. And clearly, if there's a high risk, if the burden is extreme, but the intervention is effective, you have highly motivated patients. And that's the point, that we should be able to translate the information of genomic medicine into an algorithm that would be consistent with a person's worldview and life's priorities. Because that is how we will affect change. Now, bringing this into clinical practice presented yet another problem, and that is that we are busy. You're lucky if you have 15 minutes to spend in detail on a patient. And where in the hustle and bustle of people pulling up or down their pants, filling in files, or you spending time with a medical aid on the phone, where do you now think of introducing a genetic test outside the routine of your regular practice? Now, of course, this is the choreographed dance that we are supposedly to do in general practice. We're very lucky if we touch on some of these things. And I had to be brutally honest with myself, realizing that often the urgency of the patient's need determines where we go. But I had to realize that I would think about genetic testing at 3 potential points. That was the when. Then I had to think about the why I would do it. And finally, the who. And those are the last primary parts of my presentation. The first when was when I had a chance to gloss over the patient questionnaire, and I have a detailed questionnaire that patients complete where the family history would give me an opportunity to at least have a mental check whether a genetic issue should be considered. And that should almost be a rehearsed step. The second was when the inevitable laboratory results came back. Because many times elevated homocysteine, changes in iron, or various other factors, maybe drug levels, or a cancer result, may come back and prompt you to think about whether or not genetics may assist you in managing the case. And finally, when I poise my pen for prescription, that would be the time that I would think, well, is there something unique to this individual that may be relevant before I commit them to whatever course of therapy I plan to prescribe? Now, the why would I think about genetic testing was also important. Am I going fishing? In other words, I don't know, there's something wrong with this guy, let's go look. Or would I be in hunting mode? I think that we need to unravel it along these lines. Or was it, well, I know what's going on with this person. He's already diagnosed, he's on medication, doesn't seem to be doing well, but maybe I can season him better if I have access to additional individual information. And this has been very helpful, both in preparing patients and also organizing my own thoughts around it. And lastly, and I'm rather fond of mnemonics simply because I tend to remember them, what I thought to do is to identify the types of patients. And I don't know whether you know that about your GP, but we tend to have this photo album of types of patients in our mind. We don't necessarily do it consciously, but there's this sort of, that's a Mrs. Jones-like situation, or that's a Mrs. Smith type situation. So you have this catalogues of patterns and abnormalities and prompts, and when I thought down, rubbed my chin over a glass of port and thought, well, who were the types of people that I thought I might help with genetics? These were the ones. And let me drill down into why I thought and have found it to be valuable. The doctor shoppers we're familiar with those people. They come in with major illnesses, major medications, and major attitudes. They've been everywhere, and at that stage, they just sort of checking you out as to whether you have a solution for their chronic illness. What I've found is introducing the individual aspect of their problem with a genetic test gave me an opportunity to identify whether these people were actually interested to be helped, versus really just there to be disappointed yet again in advance. Those who did undergo testing, I realized that one of the goals was to objectify and to add resolution to understanding their condition. And it's tremendous how I found that that would restore trust in the healthcare system, because I'm looking at them. I understand their situation. Rationalizing self-help. One of the wonders, I would say, about the wellness screening battery and some of the others is the way in which it gives you specific target areas to hone the self-help, health pursuit, and other types of health strategies with the patient, so that they know where they can aim their obsessiveness in a way that you then prescribe so that it is somewhat reasonable. Okay? But at least it's constructive and it's grounded in evidence. And you can shape a constructive responsibility towards maintaining health. The tests would be directed based on the situation, and the outcome is that the person has some objective assessment, clear instructions, and you can introduce a methodical screening and surveillance program. And it's really been wonderful in building rapport, setting goals, and building a roadmap towards health for these people. Then there's the odd patient, and we all have those from time to time. They just bug you. They wake you up in the middle of the night, not because they've called, but because you think you missed a diagnosis or should have done the phone call or the additional test. And those are the people that you can't quite make sense of the symptoms, but you know it's there somewhere. And whether or not you can reach an actual diagnosis or at least a functional solution, those are some of the things that genetic testing and the biochemical testing can actually lead you towards. Meaning, you can start doing something even though you don't have all the answers. And I want to use an example of our multiple sclerosis patients. You know, many people are between the question mark diagnosis, the initial course of cortisone, and whether or not they fall in a class for which disease-modifying drugs may or may not be indicated. So they're in limbo land. They don't quite know, is it the diagnosis? Is it the treatment? For now, there's nothing. In that period, having an opportunity to look at some of the key risk factors and to provide them with an active approach to maintaining their health is tremendously powerful and changes the paradigm from avoiding disability or awaiting it, but as slowly as possible, towards establishing health. Tremendous, tremendous frame shift. It then also establishes their commitment because they understand why they're doing it. And of course, there's the odd, unexpected discovery that may introduce new therapeutic options. The tests would be prescribed. The outcome could be consolation, if there's confirmation, or it might be reassurance, certainly motivation, and ultimately strategic responses. Not just an empirical healthcare pursuit, but something based on actual measurement. For the general health people, the bottom line is these are the people that are ideal patients. They want to do everything right. They may be investing their effort in the wrong place, but they want to do things well. And here you can guide them and really provide a structure in a way that they can do it. And it's really very affirming and useful. Now, you get the people that have had every disease. I mean, every box is checked. And those types of individuals, these approaches may give you common pathways, an inflammatory pathway, a methylation problem, a detoxification problem. It gives you themes, a synthetic problem, the inability to produce certain steroids, etc., or metabolize certain drugs, gives you a theme and starts bringing legitimacy and even restoring self-esteem sometimes in these patients when they start realizing it's not all in my head. Very, very helpful. And it links the health behavior you'd like to encourage with the actual challenge they're trying to overcome because you can give them an idea of mechanism. Rationalize their self-help when it's counterproductive and move them away from anti-pathology, you know, my multiple sclerosis, rather than, no, my oligodendrocytes. Let me take care of them. Let me not smoke them to death, starve them to death, beat them to death. Let me think about this differently, and it makes a tremendous difference. The health nut, we learnt about how we might approach that. It might be the zealous person or the weekend warrior, but there are ways in which we might approach this person's risk and use these tests to guide their journey. The person who's frustrated on medication because they have all these side effects, and I can maybe drill into that even more when I look at treatment failures, and they're the well-known drugs that have come across your desk and Marita's notes repeatedly, the estrogen issues, the statin interactions, warfarin activation, opiate sensitivity, tamoxifen activation, and the many drugs in the psychopharmacology range that are affected through metabolism, those may constitute reasons to consider genetic testing. The expected outcome is that you can actually change prescriptions, rationalize drug interactions, and come up with something that the patient has confidence in and at least has a sound basis. I would add to that, because it's related to some extent, the impending chronic meds. I no longer put patients on chronic high blood pressure medication or chronic anti-cholesterol medication without strongly having considered the value or potential value of a genetic test. Considered over the remainder of their lifetime and the cost of the medication, the potential side effects, and their commitment to it, I feel that I owe them that much as I do an ambulatory blood pressure test to truly have a proper appraisal of their blood pressure cycle. So that's the attitude that has changed. Even people who are struggling with oral contraceptives, I would start considering looking at it differently from a genetic point of view. Cancer, I don't need to belabor that. It's a specialized area about the risk itself, the type of tumor, the chemotherapy issues, and of course drug effectiveness that may all be elaborated through genetic testing, and the solutions and the cautions that they may give us. And then finally, last but not least, the sick families. And that's the conventional or classic genetic testing, and here we have clear objectives, and we want to do that in a responsible and an ethical way. And they would be prompts for genetic testing. So those are 10 groups of people that I've realized are sort of poster children that would prompt me to think about genetic testing. Not because I'd like to throw another test at them, but because I can actually improve the way I manage them clinically with that additional information, because it guides the journey with greater clarity and greater confidence. And when I'm confident, the patients are confident, and the outcomes are typically much better. Now, how do we prepare for this journey? Well, I'd like to refer you, if you haven't already registered, and I'm sure all of you have, remember that there is this electronic book that Marita is there, because I'm sure it's gone from the memory stick or your email by the time you need it. Please do make use of it. It's a wonderful resource, and it's readily available, and you just download it. It's good for the medical aids, and it's certainly good for colleagues and patients. Then the Australian website for the National Health and Medical Research Council, an amazing number of electronic downloads that are available on family practice-related genetic testing. Very useful. Many of the references or the referral information, of course, is local, but there are some excellent resources. I mentioned Francis Collins' book. If you haven't read it, read it. It really is a must read. It gives you language, it gives you illustrations, it gives you attitudes towards certain tests. It demystifies the direct-to-consumer genetic testing. It shows you the pitfalls, it shows you the actual shortcomings. It actually shows there may be validity, but there are certain areas that it misses, and you need to be aware of those. It strengthens you through information rather than prejudice. Then, for those of you that maybe are not naturally inclined towards reading biochemistry textbooks for your leisure, there is a book that I found extremely useful in preparing for my American licensing exams. It's called Biochemistry Made Ridiculously Simple. Maybe it gives you some reflection of my state of preparation, but what was really useful about this is there's a neat fold out that this book has. And it's made like a theme park. And you've got carbohydrate land and the amino acid midway, and you've got Porphy's heme land, and you've got the steroid forest, and so on. And why this was great is not only educating me, but I could stand with a patient and I could say, you know, this is where homocysteine fits in. And it goes this way, and can you see it has an effect there? And this is the enzyme that is malfunctioning. And that's why you need to take your folic acid. This is why we need to check your vitamin B12. And it engages them in the process. And they may not understand all the fancy terms, but they remember looking at this chart, and boy, it really seems to make sense. It involves them. It's really a very powerful tool. Another concept that's been so helpful to me is knowing that so much of what we're doing in genetics, and especially when we're looking at SNPs, is we're looking at the machinery that is designed to change metabolites, drugs, and various other xenobiotics from lipid-soluble to water-soluble, to be eliminated in the kidney. And we call that phase 1 and phase 2 elimination in pharmacology. And what that really is, phase 1 is the hydroxylation stage, which is through the cytochrome P450 family. All the CYPs fit there. And the second phase is conjugation. And that's where things are joined to the molecules in order to make them more water-soluble to be eliminated through the kidney. And just knowing that, just knowing there's a two-step process whereby many things are eliminated, allows you to explain it to the patient. Because they either have heartburn or constipation biochemically, right? The one's either kicking back or not coming out. And you can actually use simple analogies that allow them to understand these things. And if you want to read one chapter, probably, as far as I'm concerned, the best value for mental ocular involvement, aka reading, is the 15-page chapter in Harper's Illustrated Biochemistry on xenobiotic metabolism. It starts demystifying how the nomenclature for the CYPs came out, where this fits in, and how you can apply it in clinical practice. Really a very, very worthwhile read. Now, the direct-to-consumer genetic testing was mentioned earlier, and I know there's the shop of horrors concern that we have, particularly coming from a conventional medical background, but it has some utility. I've walked a journey with a person diagnosed with bipolar disorder. The person had been on 39 medications over 15 years, and this didn't work, that gave side effects, this made her fat, that made her this, it was a mess. She'd been through every psychiatrist in the Western Peninsula, but she had not found solutions. And one of the things that just happened by chance, because I was so desperate, this was early days, I said, well, Marita, I've got this person. Do you mind? I'll write this article for you if you'll test it for free type thing. That was how it started. And we found that this person had a CYP2D6 mutation. And suddenly a world opened to me and opened to her. Because she could finally pull a thread on why the medication was causing problems, why this one affected that one, why she felt the way she did. It changed her. It changed her psychiatrist, who has adjusted prescribing and has a completely new perspective on that aspect. And it certainly changed me, because we had not found solutions and we had really, really searched. But what brought me to that is on this website, Cure Together, they actually have 630 conditions that people can enter, the condition they're suffering from, the symptoms, the treatments they've tried, the treatments they haven't tried, how they work and haven't worked. And ultimately, they have access to a plot that shows them the treatments that are used around the world for a particular condition. The things that allegedly are particularly popular but don't seem to work. The things that are popular and successful, the things that are very effective but nobody uses. And what it allows you to do is you can actually navigate this and you can dispel certain fallacies and you can counsel the person and they actively part of the process. And yes, I know you would have picked up omega-3. No, if you swallow your omega-3, you're not going to have a better day. So you do need to put it in a clinical context. But it still provides you with a tool, an empowerment tool, that makes an enormous difference to patients and is something we should consider looking at. And for the budding researcher, one of the things that they're doing is they bring these association studies. Now, admittedly, it's like a cluster analysis. You'll get things like most women are female. I mean, yes, you'll get those sort of associations, but you will also get polycystic ovaria, iron deficiency. Or you get these strange associations within the group that not only had biochemistry and clinical data, but actual genetic testing. I'm not saying this is Nobel Prize-winning Lancet material, but it is a place to look. And it's certainly a place to start looking at the comorbid or associated conditions, because that's how we're going to start narrowing the search. Now, I don't know about you, but I certainly don't enjoy drawing genograms and extracting the family information from my patients. So I was delighted that this United States Health and Human Service website provides you with an interactive tool, free, no strings attached. It's actually quite a pleasure. You go into the family history side, and it gives you a very pleasant interactive site with narrowed margins of age, so they don't need to remember that Auntie Sally was 23 and a half when she got diagnosed. It gives you ranges. It gives you the typical inheritance that would be of interest, plus the opportunity to add others. It allows the family members to send it to one another to add the details. And you can print it out as a PDF or export it as an XML, which is essentially a very compatible file format. And it's free. Now, if you've got proprietary information that does that for you, God bless you, but I don't. And this has been wonderful in giving me things like this that are legible and can be entered into a file and are far more valid than a couple of notes scribbled while sitting in the waiting room coming to see you about their family history. especially if you take a few moments to explain how important it really is. Okay, there's some very good websites about pharmacogenomics. This is by Stanford University. They actually are publishing the clinical variants, and we've been given permission to actually access this file so that we can actually look at whether there is a worthwhile field to examine. For prenatal screening, Francis Collins recommends the March of Dimes. Franklin Roosevelt, one of the US presidents who had polio, actually started this, and they have some excellent resources that you can register for. So those are just some things you might be interested in. Everything isn't a click of a mouse. I realize that. But it is about involving our patients. And I think what new genetics or genomics has added is restoring some of the dignity that the epidemiological and the other statistical and sort of generic evidence-based approaches have robbed. It brings back the personal element. It brings back the individual element. And I think that's powerful. And I think it's something we should work with clinically. In spite of its frustrations, clinical work has its rewards. It is a unique opportunity to interact with people. And the genetic information that I've discovered in working with the colleagues here has really added a new dimension in how I relate to my patients. Thank you very much.